Thank you very much. And of course, it's my great pleasure to introduce Professor Taweesak Tanwandi, who is the current president of the Thai Association of the Liver, and he's an associate professor of medicine. He's a head of gastroenterology, Department of Medicine in Siriraj Hospital, Mahidol University, Thailand. He's also the president of the 4th ASEAN Perspective of Liver Disease today, and he is going to talk to us in this presidential lecture about novel endpoints of HBV therapy in the 21st century. So we look forward to your talk, Professor. Thank you.
Thank you very much, Professor Lim and Professor Thongsavat, for your very nice introduction. It's my great honor to be here to present these presidential lectures. Actually, when I got assignment from Tira regarding the topic of the talk, it's going to be very, exciting. And I'm thinking what I'm going to do for the topic, a novel endpoint for the treatment of chronic hepatitis B. So I just think about how I'm going to do to complete his assignment. So I'm going to try to divide the topic into 4 parts: the natural history of chronic hepatitis B, current treatment and endpoint and goals of the treatment, and how much the current endpoint and goals are currently achieved, and what should be the best or the novel endpoint for this century. So when we look at the natural history of chronic hepatitis B, so this is I think the best possible endpoint for anyone who has exposed to hepatitis B would be acute infection that can spontaneously clear the virus. That can occur up to 90% for adults, but just less than 5% for those who infected perinatally. This is the best possible endpoint, I think, for those who unfortunately exposed to hepatitis B. So what I would say now, if I can achieve the novel endpoint, would be someone that can clear the virus, somewhat like those who can spontaneously clear the virus, like in acute infection. That would be the novel, and would be the forever novel endpoint. So I can finish here, because this is a novel endpoint that I would say. So now, when we look at the natural history, for those who unfortunately cannot clear the virus, so this is an arena for those who chronically infected. They're going to go through multiple phases of infection, from immune tolerant to immune active, where the fighting between the immune system and the virus. And then if the immune can succeed the virus, that's going to be immune control. And up to a third of the patient can reactivate after a period of immune control. And for those who can spontaneously clear surface antigen, like Professor Lim said yesterday, so this is going to occur up to many percentage of the patient after age 45. So this can be called occult hepatitis B infection. That means the S antigen are negative with positivities or of immune to surface antigen, with very few copies of hepatitis B left in the body and very few cccDNA left in the liver. So longitudinal follow-up of the patient with chronic hepatitis B, you see that they have gone through so many fighting during the course of the chronic infection that leads to chronic liver disease, and some lead to cirrhosis, and that could be precursor of hepatocellular carcinoma. So when we look at the guideline, most of the treatment guideline has the objective of improving quality of life and survival. This is the most updated guideline so far, the AASLD 2015, EASL 2012, and WHO APASL and Thai Guideline 2015. So this goal is aimed to stop disease progression in order to prevent cirrhosis, decompensation, hepatocellular carcinoma, or in order to prevent premature death. So what is the current endpoint and how satisfactory with this endpoint? So when we look at the guideline, this is the aim, the ultimate goal of the guideline, how we can improve patient survival in order to reduce complications along chronic infection. But maybe the stopping point of the treatment can be stopped after the patient has lost surface antigen. And this is the point that the treatment can be stopped, but it takes so long. So most of the treatment in clinical trial has looked at the so-called surrogate endpoint, either improving of histology, loss of E antigen or E seroconversion, normalizations of ALT, or suppressions of HBV DNA. So this endpoint we can call surrogate, because the ideal surrogate endpoint would be it is easier to assess, and it is corresponding to the endpoint that should occur in the future, and must explain the effect of subsequent clinical outcome. So when we look at the endpoint like ALT, the ALT is for the broad side of ALT it is a baseline indication for the treatment. So most of the guidelines have looked at abnormal ALT before the treatment commenced. And this could be the baseline predictor of response and post-treatment response. However, for the con side of ALT, it is fluctuating, and the normal values may not be normal. This is the famous study from Professor Maria Boneto, who's here, looking at chronic hepatitis B negative in 2002. So when you look at the natural history of chronic hepatitis B negative, so you see that majority of the patients with chronic hepatitis B negative have fluctuating enzymes. So just less than half of the patients that have persistent elevation of the enzyme. Now, another study from Hong Kong, from Professor Yuan, when he looked at the normal value of the enzyme, so you see that in the red bar, if the enzyme less than upper limit of normal is either less than 0.5 to 1, or even less than 0.5, the risk of liver-related complications is still higher than normal population. So normal in ALT doesn't mean normal, or doesn't mean that the patient can get away from the risk. So the last study, this is from Korea study, Professor Kim has mentioned that in the insurance study, so the normal value of ALT may be less than normal that we have set so far. So currently, for example, for the AASLD guideline, the normal ALT for women going to be like less than 19 and less than 30 for a man. How about HBV DNA? So HBV DNA among the most solid endpoint for every clinical trial. However, when we look at the clinical trial from 1990 with conventional interferon and lamivudine before 2000, you see that they have used the least sensitive DNA hybridization with the detection limit of around 10 to the 5 copies. Then after the year 2000, we have moved to PCR-based quantification. However, at the beginning of PCR-based, we have the problem with high viral load, because the dynamic range of the detection is going to be like less than 1 million or 500,000. So anything above that is going to be diluted and retested again. However, DNA quantification may be among the best possible endpoint at this time because this is linked to the natural history. When you look at the famous review study for the people having DNA greater than 10,000 copies per mil, the risk of SCC and cirrhosis pretty much higher than those who have less than 10,000 copies per mil of the baseline HBV DNA when they follow for 13 years. And for those who have persistently high HBV DNA, the risk even higher as compared with for the patient who had high HBV DNA at the beginning, but during the follow-up, at the end of the follow-up, HBV DNA below 10 to the 4. When we look at the effectiveness of the DNA suppression with our current treatment, lamivudine, adefovir, and entecavir, tebividine, tenofovir, and PEG interferon, please bear in mind that this is not head-to-head comparisons, or it's not the same study. When you look at it in terms of DNA suppression, you say that entecavir, tebividine, and tenofovir are among the most potent drugs that can suppress the virus. However, even you continue treating the patient for many years, once the treatment is stopped, this is a study from Hong Kong. They have shown that in chronic hepatitis B negative patients who have been successfully treated and suppressed the virus for many years, once the treatment stops and they follow, and you see that at 6 months and at 1 year. At 6 months, 74%, and at 1 year, 91% of the patients had HBV DNA relapse greater than 2,000. So that means you're going to continue suppressing the virus forever or until the patient can successfully clear surface antigen. How about E seroconversion? I think E seroconversion this is the most popular treatment endpoint, especially for E positive chronic hepatitis B. And study from Taiwan have shown that the patient who can clear E antigen has much lower risk of SCC as compared with the patient who persistently having E antigen positive in men of about 10,000 men. Now, can this endpoint achievable? This is the study from many clinical trials, from PEG interferon and NUC. You see that 1 year of NUC or PEG treatment can achieve surface and E antigen seroconversion for NUC, just about 20%, for PEG interferon, just about a third. However, can we extend the treatment, especially for the NUC? This is a study when we extend the treatment longer than 1 year, 3, 4, 5 years. You see that less than half of the patients can eventually clear E antigen, but not all of them. So we cannot rely upon E antigen seroconversion for majority of the patients with E positive. So again, this is not a good endpoint that we can achieve for most of the patients, even with E positive. Moreover, even the patient who achieve E seroconversion, this is a study from the Netherlands looking at those who can achieve E seroconversion and after stop the treatment for lamivudine, interferon, or interferon plus lamivudine. You see that majority of them will have some relapse of or reversions of E antigen. Moreover, some of them have relapse of DNA with E negative. So it can be either reversions of E antigen or relapse of DNA with E negative virus. So that means E antigen seroconversion cannot guarantee the patient can be safely stop the treatment. How about histology? This is among the most solid endpoint we have looked at. We try to confirm that the treatment can associate with improvement of histology. This is a famous study from tenofovir, 5-year straight of tenofovir treatment by Professor Maslin from Paris. He looked at the baseline histology and 5 years after tenofovir treatment. Any color from orange, blue, and green, this could be advanced fibrosis. So after 5 years of treatment, this color become very small. So that means majority of the patient has improved histology and regressed or reversed fibrosis or cirrhosis. When they look at ECHAC's fibrosis scores, you see that about 74% of the patient can result from so-called cirrhosis. So this could be reversal of cirrhosis. How about long-term complication? All of these treatment endpoints, does it mean this can reduce long-term complication? This is maybe the only study that compares placebo with treatment, the famous CLAMP study by Professor Liao. They have looked at treatment with lamivudine versus placebo. So the treatment can significantly reduce the chance of liver-related complication as well as the chance of getting HCC. So this is the confirmation that the treatment is good, so we should offer the treatment. However, when we talk about HCC, Ray just mentioned about the HCC surveillance. When we talk about HCC, the risk reduction after treatment, this is a study with entecavir from Japan, compare control and entecavir treatment. So with entecavir treatment, the risk of HCC can be reduced significantly. This is after exclusions of many parameters. Ray did the study with tenofovir, presented a couple of years ago at the EASL. He looked at tenofovir treatment for many years to try to look at the risk reduction with the treatment. And he compared with the RISC-B model in terms of risk calculation for HCC development. So in the patient with cirrhosis and non-cirrhosis, the risk of HCC got to be, the incidence got to be 1.5% for non-cirrhosis and 4.5% for cirrhosis. Now, when he compared with the RISC-B model, you see that the risk of HCC eventually reduced, especially after 5 years of tenofovir treatment. So the curve separates from the predicted RISC-B model. However, the risk cannot be reduced to normal or to the patient or general population. This is a study that's published a couple of years ago. They look at the risk of HCC. This is inactive chronic hepatitis B, and the red lines represent inactive liver cirrhosis. So for those with chronic hepatitis B, no cirrhosis, the blue bar, the blue lines, you see that we can actually reduce the risk of HCC for those without cirrhosis and successfully suppress the virus to just the risk of HCC in inactive hep B cirrhosis. So eventually we cannot reduce the risk to normal. So there is something in the patient that we cannot manage. So maybe for hepatitis B, this could be multiple factors for the risk of HCC. That can be the residual histology in the liver. This can be integration of hepatitis B and part of the hepatitis B protein that can integrate and can result in the integration in the liver or result in alteration of the oncogenes. When we look at this is a scenario for hepatitis C. For most of the patients with chronic hepatitis Hep C successfully treated who got SVR, 61% achieved significant regression from cirrhosis. For the baseline cirrhosis, 61% after 4 years, repeated biopsy, the cirrhosis gone. However, when they look at infrastructures or in detail, for example, CD34 for the sinusoidal capillarization. So for the cirrhosis, the sinusoid is not sinusoid anymore, it's become capillarization. So capillarization of the sinusoid remains even after the gross histology has shown improvement of cirrhosis, and also the activation of hepatic stellate cells remains. So there is something going on in the liver. This is going to be maybe towards the point of no return. So it can be some intrinsic factor that remains, and then that can pose intrinsic risk of SCC. How about S antigen loss that we are talking about? So recently, there is a proposal. This is from Professor Fabien Surim from Lyon, France. He had proposed that we would define the cure for hepatitis B, functional cure and complete cure. Complete cure, that means completely clear cccDNA from the patient liver and or maybe from the whole body of the patient. But for the functional cure, this can be called occult hepatitis B, so it's S antigen loss or S seroconversion with some remains of cccDNA. So when we look at the study again from Hong Kong regarding the S antigen seroconversion, so if we can achieve S seroconversion at early age, mainly before age of 50, the risk of SCC is going to be much lower as compared with those who has clear S antigen after the age of 50. So if we got to do to this patient and we want to achieve S seroconversion, we better try to clear S antigen before the age of 50. So now, let me wrap up. This is the most current guideline. So from the original guideline, we have looked at successfully suppress the virus, E seroconversion, ALT normalization, and improvement in histology. But for the current guideline, every guideline, the endpoint of the treatment is lost surface antigen. So we will continue treating the patient until they have shown surface antigen loss. However, when we look at the natural history, this is Henry from Hong Kong did a study to look at the S antigen titer decline during natural histories of chronic hepatitis B, especially after spontaneously E seroconversion. You see that there was significantly drops in HBV DNA, but not surface antigen. So surface antigen is still there. So the rate of surface antigen decline is very slow. Actually, for the treatment-induced surface antigen loss, that's even lower. A study from Taiwan have looked at the patient successfully controls DNA with NUC. Surface antigen decline got to be about the same rate as the patient with inactive chronic hepatitis B. So the French colleagues proposed that it might take some 50 years to clear surface antigen. So how can we clear surface antigen before age of 50? Because even at the time of the treatment, the patient might be my age like 30, 40, so it takes another 50 years to clear surface antigen. That is too long. And when we look at the treatment potency now, the rate of surface antigen clearance is very low, so less than 10% for majority of the treatment, even continue for such a long period of time. This is because of the slow kinetic of surface antigen loss during the treatment. And most of the surface antigen clearance occurs in genotype A, that is in Caucasian. So when we look at the endpoint, again, I think that the treatment endpoint that we can aim or we can dream for is still loss of surface antigen. We don't want to achieve complete virological cure. I think functional cure it is good enough to achieve. However, how can we bring the clinical trial? So the endpoint of the clinical trial is the same as the endpoint of therapeutic treatment. So that means how we can set up any treatment that we eventually achieve surface antigen loss at the end of the treatment, but not 50 years, but we would like to have like a few years, 1 year or maybe just a few years, not lifetime treatment. So now, we not only want to clear the virus within a short period of time, but we want to clear the virus at the earliest time point. So maybe we would like to look at the immune tolerance phase, how can we move the patient from immune tolerance phase and to move this stage, bypass these stages to this occult infection as soon as possible. So what we would like to aim for and dream for is try to move the patient with immune tolerance phase at a younger age to the phase that they can eventually clear surface antigen without leftover histology or leftover abnormality that can successfully prevent it from occurrence of chronic hepatitis B complication and SCC. So by doing so, I think we need multiple drugs. With the current treatment, it's not achievable because we can achieve just a few percentage S antigen loss. So we need more drug, more mechanism to induce immune tolerance, loss of immune tolerance, and then how we can clear the virus and also clear surface antigen by stimulation of the immune system. Hopefully, with the current drugs in the pipeline, in order to silence the DNA, try to reduce the reservoir in the liver, also to prevent re-entry of the virus into the liver cells, also have the drugs act internally in the liver cells. Hopefully, all of these drugs in the near future can do that job, and we can achieve surface antigen loss in pretty short period of time. So in conclusion, ladies and gentlemen, the novel endpoint for hepatitis B treatment in this century, the idea I would say, how can we bring the patient, and these patients are the patients with chronic hepatitis B, how can we clear the virus and clear the liver without leftover pathology or abnormality, like in the patient who have spontaneously cleared the virus in acute hepatitis B infection with S negative, antibody to surface antigen positive, anticore positive, that is natural immunization of the patient. So in doing so, this is not completely complete cure. This is just functional cure. But functional cure is good enough. We can have sustained surface antigen loss with few cccDNA. This is nothing for a normal host. So it might be a problem for the patient with immune suppressed, but it's not a problem for normal host. So final word for me is the novel endpoint that Tira gave me is the oldest marker that we have discovered, the Australian antigen. The first marker got to be the best marker for the endpoint. Thank you.
Thank you very much, Mr. Tanwandi. Since it's a presidential lecture, there'll be no questions, and we'll move on to the opening ceremony.